Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Sarah Drenick, and this is part one of the two-part webinar series of focus on the major impacts of the new requirements of participation. Before I introduce our presenter, I'm going to quickly review a few housekeeping items. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines will be on mute for the duration of the presentation. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure you send your comments to all participants, as we will be monitoring and responding to questions and comments in chat. We will also have plenty of time for questions at the end of the presentation, and we'll open the lines back up for you. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now I'm pleased to introduce today's speaker. Dr. David Gifford is the Senior Vice President of Quality and Regulatory Affairs at the American Healthcare Association. He helped create the department, which assists providers in their quality improvement efforts and works with administration officials on regulations and policies impacting the profession. Dr. Gifford also serves on the board of the Advancing Excellence in America's Nursing Homes campaign and the Baldrige Foundation Board. He is a former director of the Rhode Island State Department of Health, where he received the National Governor's Award for Distinguished Service Award for the state officials, and was the semi-finalist for the Harvard Kennedy School of Government Innovations in Government Award for his work on the nursing home survey process. Prior to that, he served as Chief Medical Officer for Quality Partners of Rhode Island, now Health-Centric Advisors, where he directed CMS's national nursing home-based quality improvement efforts. He received his medical degree from Case Western Reserve University and conducted his geriatric fellowship at UCLA, where he earned his master's in public health and epidemiology. Dr. Gifford, welcome. I'm going to turn it over to you.
Well, thank you, Sarah, for the nice introduction, and it's nice to be back talking to people in New England on this. The requirements of participation went into effect last November for some parts. Another set are going to be going into effect this coming November, and then some in 2019. The sections that are changed in our requirements are pretty extensive. This is really the first update in over 20 years of all the new regulations. And I'm not going to be able to go through all the changes, but the ones that are highlighted in red on here are sections that are either new or so dramatically rewritten that they really are essentially new functions. And I really encourage you to certainly read all of the requirements, but certainly focus on the new areas because they may impact you a great deal. As I said, CMS is implementing these in 3 phases. Phase 1 was implemented last November. What we've heard from around the country, including New England, very few states actually did much with the new regulations. A lot of the stuff that was in Phase 1 was already out in S&C memos. We already had to follow a number of it. And many of them were waiting for guidance from CMS and the interpretive guidance and new training that was going to come into effect for this fall. Phase 2 is effective this fall. And then Phase 3 are things in 2019. And the reason they did the phase-in was, one, is both to allow people time to implement all these changes, but also some of the things take time to implement. So if you're waiting for the last minute to implement Phase 2 and Phase 3, you're going to have a lot of trouble because some of them take more than a month or two to try to make those changes. This is clearly going to have an impact on the new survey process. CMS has developed a new survey process. It merges the QAS survey with the traditional survey. It incorporates these new requirements, and it's going to go into effect this November. And CMS will start training all the state surveyors later this summer all the way through the fall. CMS is said that they will make all the training available to the public as soon as they make it available to the surveyors this summer, so we can actually see the same information that the surveyors are going through in the training. This change will not only change the survey process, but is also going to change the survey focus and the types of tags. They also are going to renumber all the tags. So 441, that equals infection control, will have a new number going forward as well. So you're going to see a lot of changes in it. The survey is going to focus a lot more on person-centered care, staff competency, and observation of care delivery, rather than on sort of paper compliance issues that are out there. There are four broad themes in the rule I want to talk about before I get into the details of the rule. The first is there's a much greater emphasis in this rule on person-centered care. Greater involvement of the person and their representative, and more notifications. And you'll see it in the resident rights sections. You'll see it in a number of areas. Basically, the way to approach this would be if you have the fleeting thought of should I ask the resident or the representative, or should I let them see something, the answer just is always yes. And if you do that, you'll meet almost all the new requirements. If you have the fleeting thought and don't do it, you're likely to get yourself in trouble with the new rule. So just remember, any involvement, the more involvement of the resident, the more involvement of the resident representative, the sharing of information and documents with them, the more you do that, the more you'll be in compliance. The second broad theme is monitoring and taking action, particularly monitoring of staff competencies. So it's no longer just to hire staff with the right training to have staff attend in-services. We really want to see that the staff has the competency and are able to actually apply it out in practice. So as I said, in the new survey process, the first day appears to be, from some of the early indications from CMS, we'll have the surveyors just observing staff provide care and seeing how they provide care consistent with requirements, consistent with your policies and procedures that you have in your facility. A lot more monitoring of adverse events, collecting adverse events, how you act on those adverse events and take action on it, and a greater focus on medication prescribing, trying to actually improve medication prescribing. And I'll talk about that a bit more in the pharmacy section. Two other broad themes are how are we aligning our resources with the resident needs, particularly how are we assessing our staffing types, our staffing levels, our staffing competencies, how are we assessing the resources, the equipment, how are we assessing the contractors, how are we assessing the environment, and how does that meet the needs? And in a very crude sense, if you were going to take care of an individual on a ventilator, you would need to make sure you have a ventilator and oxygen, a respiratory therapist, staff to handle it, access to a contractor or a pulmonologist, at a minimum, to manage someone who is on a ventilator. If you didn't have that, it would be wrong to take them. They want to take that same approach and apply that to all the residents that we have and take care of, whether they be short stay or long stay. And then there's also a greater recognition that the population is changing and that the acuity is increasing. We have more and more nursing centers that are focusing on post-acute care rehab, and we have more and more centers where the long-stay residents are sicker and sicker because they're being cared for at home or they're being cared for in assisted living before they come to us. And then last is that we're seeing a growth in individuals with chronic behavioral and substance abuse issues needing long-term care. And how do we have that, and how do we meet the staff competencies and issues for that? I'd say if you're thinking about those four broad things as you work through on these rules, it'll help you implement all the changes that are out there. I think the most important thing in how to implement and comply with these rules is the mindset you bring to the table in doing them. And this slide here shows the mindset model, which is adapted from the Arbiter Institute. And here at the top of this pyramid is where your current results are. And the current results you have are the results of the practices that you have in your facility. Those practices, how you apply those practices, design those practices, and carry out those practices are based on the mindset that you bring to the table. And I want to focus on the mindset, because it's the mindset that really ends up driving your results and the practices that are out there. And what do I mean by the mindset? Well, for example, you really need to understand the purpose and intent of the rules and regulations. If you approach your practices that you're going to comply with the regulations versus you're going to practice for the purpose and intent, you're going to have a lot of trouble. If you practice for the purpose and intent, you're going to allow you to have flexibility when facing unique and exception to the rule type individuals. So I hear all the time people saying, asking me questions, well, how long does CMS want me to do this? Or what do I have to do, or who do I have to do it, or what day do I have to do it? It says 48, when do I have to do this time frame? You don't really want to ask those questions, because then you're going to get a detailed answer from CMS, and our response is going to be, well, we can't possibly meet that. That doesn't make sense for this individual, that doesn't make sense for that. And so we want the flexibility, and we want to practice the intent and process. So, for example, if you approach, and talk about this later on in the QAPI section, if you approach root cause analysis and you assume that everything is not preventable, you will not find things to make changes. If you assume in your root cause analysis that this was absolutely preventable, you know it's not, and it's not always preventable, but if you approach it with that mindset, you will find all sorts of things to fix and make different in your facility. And so again, everyone does root cause analysis, that's the practice. But the mindset you bring to the table will dictate how well and effective that root cause analysis is. And this goes to the person-centered care aspect of it. It goes to the monitoring and action aspect of it. It goes to the new acuity aspect, and it goes to how you're aligning resources. That mindset you bring is really key. And I think that's the biggest take-home message I could leave you with today on these new rules. I think the next step, if you haven't done it already, you really need to read the last 30 pages of the final rule that have all the new requirement language in there. And it's laid out by regulatory section. Now, some of the language in there is actually old regulation. It's just that it didn't make sense to leave it out. For example, immunizations have not changed at all, but are still in there, but they rewrote the infection control section, and they moved immunizations under it, so you'll see that there. So just because you're reading the last 30 pages doesn't mean it's all new. But it definitely is all the new areas or reorganized areas, and you really need to read it, because you're going to hear all sorts of rumors, you're going to hear stories from other facilities, you're going to read things in McKnight's or newspapers. Surveyors themselves are going to say you have to do something, and they're going to make mistakes on this. And so I really encourage you to read this, have it with you as you sort through, is understanding what the actual language is. Even some of the interpretive guidance, draft guidance we've seen CMS developing for the surveyors has had some mistakes in it as well. And some of the material we've developed for our members of HCA have had mistakes in it as well, and people who have gone back and read it have pointed that out. So again, I think if you have one set of homework to do after this, is read those 30 pages of the final rule. I would not encourage you to read it at bedtime. It is not bedtime type reading. All right, let's talk about the different sections. I'm not going to go through all the sections. We don't have time to go through all the sections. And even within the sections I'm going to cover, I'm not going to cover all the aspects. So I want to highlight those sections that I think are most important to patient care and will most likely have the greatest impact on the clinical outcomes of the residents we care for that are out there. Also the ones I think represent the biggest change in practices that we would have to do in our facilities. So there's a lot of new issues around care plans. So a phase 2 new requirement is that we all have to have a 40-hour baseline care plan. Now some states already require this under state regulations, but under new Medicare and Medicaid regulations, we all have to have a baseline care plan. Now, this is an area where people, this is a requirement to meet the minimum standards to participate in Medicare and Medicaid. You can go beyond the minimum, but if you write rules and policies and procedures to go beyond the minimum, CMS will hold you accountable to what you go beyond, and then you have to comply with it. So don't make this more complicated than need be. And what they've laid out, I think, is pretty reasonable when you think about what the intent and purpose is, which is the intent and purpose is to make sure, as we have higher acuity individuals coming into our building, that the team that takes care of them understands what are the goals for the person's admission, what are the physician orders, medications, what are the dietary orders, therapy services, what are some major social service aspects, and then any PASSR recommendations. CMS is really going to be focusing on PASSR. I think that they are recognizing that PASSR for a long time has been a paper compliance joke in the country. That's my opinion, not CMS's. But I think they really are ramping up the PASSR component. It would be nice if they also brought this into the hospital, because a lot of it starts in the hospital and we've delivered that message to CMS as well. But I think that there's a greater recognition, as I said, of chronic mental illnesses coming in and masquerading and being hidden under clinical diagnoses, and how do we make sure they meet those services. This does not mean you have to have an exhaustive set of therapy orders, therapy or social service notes there. Again, this is because of higher acuity individuals. How are you going to make sure that the team knows some basic things and the families and residents know? And you're supposed to share this baseline care plan with the families and residents. And people say, well, how soon do I have to share them? My answer to you on that is, well, how soon would you want them shared if you were a family member? And you want the flexibility, because some family members and the residents may not be able to get access to it right away for legitimate reasons. And if we get an answer that it has to be shared within 6 hours and 23 minutes, that won't be possible. And so, again, they don't specify how soon you have to share that with them. So, again, I would approach this from the intent of how do you make sure that the team is taking care of individuals and the residents know why they're there, whether some of the basic orders or admissions, until we can get the comprehensive care plan put together. This is meant to bridge the time between the two. There's some changes with the comprehensive care plan. Many of these were in phase 1. I just wanted to highlight some of those things that we need to put in that care plan. As I said, most states have not been focusing on the phase 1 requirements because they're waiting for the guidance and training that will come this summer to do this starting in the fall. But now, in our comprehensive care plan, in addition to all the things we've always had to do, you really need to have a section on the residents' strengths, goals, some of their desired outcomes, and some of their personal cultural preferences so you can make them more person-centered care. And you also need to specify their preference for future discharge and desire to return to the community, even if it's not returning to the community as possible. If they want to return, you should document it, but then you need to document why they can't and who made that decision. The measurable objectives and time frames to meet the resident needs. So they really want us to not just say the person's here for rehab, but why are they here for rehab? They're here to be able to go home so they can be able to negotiate one flight of stairs, be able to cook by themselves, be able to transfer by themselves. But they don't need to be able to dress by themselves. We don't have a home health maid helping them dress. That's a very more detailed, measurable, objective time frames. And then now the team understands what they have to do and how to make the person get to home. It may change over time, but you have to modify that. Again, the PASSR findings need to be incorporated in the comprehensive care plan. The one thing we have heard that a number of surveyors have been looking at across the country is they've been asking and looking at the PASSR in both the comprehensive care plan and how people are addressing it. There's a new section in the comprehensive care plan is you need to have a discharge plan. I'll talk a little bit about that in a second more, but you need to have a new discharge plan. And this is for everyone getting admitted, whether they're being admitted for long-term care or short-term care, because even some of the people who come in for long-term care may, over time, be able to get well enough or things change at home or in the environment so they can go home. Any referrals you make to local contact agencies or other entities to figure out whether someone can go home and what the needs are met are there. It has to be prepared by the IDT team, as it's always been, but they've added now that you need to have a nurse's aide who's responsible for the resident, as well as a member of food services on the IDT team to do that. And then you need to document that the resident and the resident representative that was, to the extent practical, was involved in the development of the care plan. And if they couldn't get involved in it, why they were not involved in it. Remember I said go back to if you have any thought about involving the resident or the resident representative, sharing any documents with them, you should do it. And if you can't, document why, and you'll meet the rules. But here they specifically state that. Okay, let's shift over to discharge planning process. The discharge planning process, this really comes about because of the changing population, the higher post-acute care, and this really intent and purpose here is to figure out how we can partner with the resident and their family and their representative to maximize the likelihood that they'll be able to return to the community if they want to without having any complications when they return. So there's a lot in this intent and purpose. So they can figure out, can they go home? And we have to be able to work with them on getting there And then we also have to make sure that they get home, they have care coordination and access to care once they get home, so they don't get readmitted back to the hospital or have complications from the issues that are there. This came about because of the information here on this slide, which shows how Medicare fee-for-service patients flow through the system. Starting on the left-hand side in the gray box, most all admissions to SNF start in the hospital. So if you look at Medicare beneficiaries, 20% of all Medicare beneficiaries in a hospital are discharged to a SNF. Another 20% are discharged to home health, and the 60% then go home. Of those 20%, which represents 2.2 million Medicare admissions a year, during their SNF stay, about 1 in 4 go back to the emergency room into the hospital. About 50% go home or to assisted living. About half become long-term nursing home resident. About 5% die during their SNF stay. Many of those deaths are expected and are related to their being enrolled in hospice. But once they get home in an assisted living and nursing home, about 1 in 5 or 20% are going to be rehospitalized in the next 6 months. And so the question really is, how do you break this vicious cycle that Medicare beneficiaries, once they get discharged from the hospital, are flowing through the SNF, going home, going back to the hospital, through the SNF, going to the ER, back and forth, and that's costing the system a lot of money, and it's really harming a lot of the elderly. So a lot of the discharge planning process is intended to figure out how to break this cycle. The discharge planning process, the major steps in it are on the next 2 slides. So again, remember to be part of the comprehensive care plan. So you need to have an interdisciplinary team develop it. You need to know the residents' goals. You need to know the discharge planning process, whether you think they can go home or not, and whether who made that decision. You need to make sure there's a plan with that. Update that discharge plan as the resident status changes. Share the plan with the resident. Does not specify when. And if you're asking me when, I'm going to say, well, when would you want it if you were a resident or you were the family member of a resident in the building? You need to prepare the resident and the resident representative for discharge, work with them to make sure they have the right capacity, competencies to manage individuals at home, access to services there. This does not mean telling them what to do on the way out the door. There is a requirement to notify ombudsman of all discharges and transfers. CMS is planning to change that and modify that. They've asked for guidance on that. And so I will leave it up to your state and what your ombudsman and your state survey agency say they want to do on that. But CMS will be modifying this over time. They asked for too much at the early part of this. But if you certainly have any controversy discharges, involuntary discharges, I would certainly send that information over to the ombudsman. You need to document the reason for discharge to transfer, which has been always the case, and that hasn't changed, but I think CMS is going to focus more on that. There's a big emphasis on providing required information to the receiving provider, because inadequate information, as many of us have experienced that we get when our individuals are transferred from the hospital to the SNF, is a result of why people go back to the hospital right away. Well, that also applies when we discharge people home to home health or discharge to assisted living or back into the community. Inadequate information to the provider community there often results in early rehospitalization, so they want to focus on that. And then related to that is making sure that we have a discharge summary done quickly to get back out to the next team that's going to care for the individual. This slide shows you some of the information that is now needed to be available on discharge and transfer. So many of it is static information, so I would have this information ready and available in my medical records on the units, so that when admissions or transfers occur late at night, on weekends or holidays, not everyone's scrambling to try to find the information. I might have this checklist on my unit so that I have a covering individual, or the night shift or weekend shift is not, usually comfortable with all the things, can use this checklist so they don't have to remember everything. Because usually these transfers and discharges on the weekends to the hospital are often hurried and urgent, and this is when information is often not accompanying the residents as they go forward on that. The discharge summary requires that you have essentially 5 sections to it. You recapitulate the stay. It needs to have the diagnosis, pertinent labs, courses of illness and treatment. Now, in pertinent labs, I wouldn't copy all the labs. I mean, we've gotten all admissions from the hospital where we have, a 12-inch stack of all the labs through the whole stay. That's not helpful. Really try to pull out the most recent labs or the labs that are really important that you would want to know of if you were caring for the resident. What the final status of the resident status is, medication reconciliation, what the plan is, who they will see, where they will live, what the follow-up care is that are out there, and then anything else you feel necessary in that process. Switch over to QAPI. QAPI really is, as I talked about, one of the broad themes of how to monitor and do action. The QAPI really represents that. And again, the purpose of QAPI is, do we have a system that monitors and investigates current practices relative to adverse events and increases the consistent use of evidence-based practices? Also, they want us to see the creation of teams to begin to focus on things that we identified of adverse events to achieve better outcomes. And how are we prioritizing which teams we need to do which actions that are out there? I think of QAPI really on this figure here, which is starting at the top, how are you reviewing your performance? And QAPI wants you to be reviewing your performance in all areas. How are you reviewing your performance in food service? How are you reviewing your performance in activities? How are you reviewing performance in clinical care? How are the goals and objectives that are in the care plan being met or not? Staff competencies, how are you viewing staff competencies? And if if the results are outside the realm of what you want, then how are you assessing the system? They want us to really think about focusing on the system rather than focusing on individuals. How do we pilot test and formulate a change? How do we pilot test it, evaluate it, revise the pilot, repilot test it? That really is the PDSA, Plan, Do, Study, Act model that's out there, and this is what they're really looking for. They have a lot of different lingo in the rule, and they have a lot of different material that's out there, but to me it really sort of comes down to these basic sort of steps and a process to do that. And many of the QIOs and QINs have been promoting this model for a number of years. The biggest challenges in the CMS QAPI pilot, where they work with 60 facilities across the country to implement QAPI, were three areas. First was root cause analysis, system thinking, and utilizing performance improvement projects or teams. Now, it turned out in the pilot, everyone did root cause analysis and everyone did team. But it was the mindset they brought to the table. In the root cause analysis, if the mindset was that this was not preventable, and we're going to show why it wasn't preventable, you will show that 80-90% of the time and you'll not make changes. If you come with the mindset that these were preventable, these adverse events, you will find 60 to 70% of the time things that you could have done differently. You may not have prevented it, but there have been things you've done differently, and the next time that something happens, you have something in place, it doesn't actually result in an adverse event. System thinking, again, we have been trained and mentored by CMS and the liability trial lawyers and a number of different groups to think and blame individuals. And rarely are the problems due to individuals, but are much more likely due to the systems that are out there. And then the mindset you come in, which is what is the system? How did we write the policies and procedures in a way that made it difficult for the staff to follow, rather than saying, why didn't the staff know what to do at the right time? If you're relying on the staff to do things by memory, what is the information that you have to send on transfer by memory versus having a system where there's a checklist with the information already assembled together that you can pull and immediately send out? That's sort of an idea of thinking about systems versus thinking about individuals. And then everyone put teams together, but the biggest challenge was putting teams together that actually were going to be thinking about systems, but that were actually the teams that were actually going to do the work. In the pilot, many of the teams were made up of leadership within the organization. Administrator, DON, unit managers, MDS coordinator, quality assurance person. But in reality, most of the changes and the system changes that need to occur are going to be driven by the floor nurses, the CNAs, housekeeping, dietary. And yet many of these teams lack those individuals. And so having teams composed of individuals who are going to be doing the work, who the actual changes are going to impact, results in much better effective work than we have at just around leadership. And again, these are the three big areas that I wanted to point out as you think about how you roll out your QAPI program. Talk a little bit about infection control. Infection control, again, the purpose here is to reduce the likelihood of the spread of infections and increase the appropriate use of antibiotics. When I say increase the appropriate use of antibiotics, what this really means is decrease the use of antibiotics because we inappropriately overprescribe of antibiotics way too often. So the infection control section, now you need to have 4 components to it. You have to have a plan, a policy and procedure. You have to have an antibiotic stewardship program as part of that plan. You need to bring on board an infection preventionist. That is a phase 3 requirement, so it's not until November 29. We'll talk more about that in a second. And you need to have a system for recording incidents identified under your infection prevention control plan and the corrective actions taken by the facility. And these aren't just reporting infection, but they're reporting practices that might lead to the spread. So are you tracking hand washing? Are you tracking the use of personal protective equipment? How are you doing that? And then how are you using that information in your QA committee and QAPI program to try to improve that? So let me talk a little bit about what has to be in the plan. CMS specifies that in the plan you need to have a system of surveillance of infections, and this needs to be designed to identify possible communicable diseases or infections before they can spread to other persons in the facility. So how are you tracking, certainly some of the common infections that are out there, but one area I see many people not tracking is the common winter crud, or the upper respiratory infection. That really does result in a lot of harm to our residents. People with heart failure and COPD get those viral colds. They end up often in the hospital with an exacerbation of COPD or CHF, and they spread very easily. And so how are you actually on top of that? How do you report possible infections? Who get they reported to? How to do that? One thing we've seen in a number of facilities across the country is the creation of huddles that change a shift. There's a quick huddle of the CNAs and the nursing and housekeeping saying who looks sick, who's developing the sniffles. And so people knew to be more vigilant with hand washing, personal protective equipment, and maybe even not taking that person into activities or into the dining area to limit the spread of infections that are out there. Use of standard and transmission-based precautions, the type and duration of isolation. Again, this depends on the infectious agent or organism. I'd encourage you to go to the CDC website and look up the infectious agents because they will tell you how long someone is infectious. Pretty much everyone is infectious when they have symptoms, but some people continue to shed spores, bacteria, or viruses after the symptoms go away. And so you want to make sure that you know how long someone can keep spreading the illness after symptoms so you don't take them out of isolation too soon to spread the illness to other residents or to staff. Again, how do you prohibit employees with communicable diseases or infected skin lesions from direct contact with residents or their food? So they can work, but they just can't be involved in direct patient-resident contact or in preparing the food. And then how are you doing your hand hygiene procedures as well? Antibiotic Stewardship Program, again, this is a program that you need to monitor how antibiotics are being prescribed, how they're being used. CDC has a whole program on their website around antibiotic stewardship. I encourage you to look at that. You also need to ask your lab for antibiograms. Antibiogram is a list of, say, the E. coli that grew in your urine cultures. How many of those cultures were resistant to Cipro? How many are resistant to Bactrim, how many are resistant to Keflex, so you can see what the resistant pattern, because you may discover that in your facility, 60-70% of all the E. coli in the urine is resistant to Bactrim. Well, then you better not be using Bactrim as the first line of treatment and a presumed UTI. Or if in your facility most of them are resistant to Cipro, you better not be using Cipro. And so this helps you begin to make sure that when you start antibiotics for a presumed infection, you're using antibiotics that are most likely going to be sensitive, more likely to treat the infection that is out there. And so if you're not doing that, I encourage you to contact your lab who does your culture results to ask them for an antibiogram to be able to incorporate that in the process. As I said, you need to have an infection preventionist. Again, this is not required until 2019, but I think it's a good practice, and many people are starting to move in that direction. So you must designate at least one or more individuals to be the infection preventionist. And those individuals are responsible for the infection prevention control plan. And the person has to have a primary professional training in nursing, medical technology, microbiology, epidemiology, or other related fields. For administrators who are on the call who are not in nursing or one of these areas, you can't be the infection preventionist. This is not another other duty as assigned that you have to pick up. I know many would pick these up all the time, but this has to be have some sort of infection clinical background. Not only do you have to have training in it, you have to be qualified by education, so you have to have either a degree or a certificate in the area. You have to work part-time at the facility, and you have to have completed additional training in infection prevention and control. CMS has not specified what that training is. A number of different organizations, including AHCA, have put such training together and have made it available out there. And I think we'll get more guidance from CMS over time. On pharmacy services, again, the goal here really is to reduce medication prescribing and administration that increases the risk of adverse events in the elderly. In my geriatric training, we were trained that pretty much all changes in the elderly are due to medications until proven otherwise. And so we're always interested in either a new medication, new dose, new route, new frequency, because most of the changes are related to that. In the individuals we care for, actually in geriatric training, anyone over 4 or 5 medications is considered to have polypharmacy and maybe on too many medications. And the literature would suggest that they're much higher risk for adverse events. Well, the population we care for in nursing facilities, their average number of medications are 9 and more. So they're really at the extreme end, and many of the problems are out there. And actually, the Office of Inspector General a couple of years ago did a review of adverse events in skilled nursing facility for individuals during their Medicare stay, and they found that the leading cause of adverse events was medication-related, and of those medication-related, 2/3 of them were potentially preventable. Other things related were relative to resident care issues, and then infections were the other potentially preventable cause as well. And hence, this report also really drove CMS to focus on the pharmacy section and infection control section. So in the pharmacy section, essentially everything has been retained, but they've added more things. In phase 1, you now need to have a drug regimen review policy and procedure. You need to audit your monthly drug regimen reviews and your medication error rates. I'll talk about who has to have a monthly drug regimen review in a second. CMS changed the definition of a psychotropic drug, and they changed the definition of what's considered a medication irregularity that would trigger an action that needs to be reviewed by the physician and pharmacist. Most of the pharmacists and the pharmacist's findings of irregularities will have to be addressed. So in the drug regimen review, the drug regimen review now must include the resident's medical chart, not just a review of the MAR. Many of the pharmacists do this. Now, your consultant pharmacists are almost all over this. Most of them are on top of this. But I would encourage you to sit down and talk with them. You must do a monthly drug regimen review if the resident is new, and has not been previously been in the center, returns from the hospital and or the other center, or is taking a psychotropic drug, an antibiotic, or any drug that the QAPI committee has requested be included in the review, in the process. An irregularity is any medication that is considered an excessive dose, an excessive duration, without adequate monitoring, without adequate indications for use, and the use and presence of adverse consequences, which indicates that those should be adjusted. I'm going to focus on a couple of things. One is on adequate indication for use. No longer is it sufficient just to say diagnosis equals drug. You can't just say hypertension equals antihypertensive. You can't. You need to explain a little bit more. It doesn't require a lengthy term paper with references and citations, but it does require a little bit more out there. And so I encourage you to think of that. Without adequate monitoring, there are a number of medications that, have known side effects, so you can get to monitor the drug levels, or they may interact with other drugs, and we need to have better guidance for the staff to sort of track that. And so I encourage you to think about that process. Now, what the criteria used for this are going to be different by different clinical pharmacists out there. So I really encourage you to get your clinical pharmacist and your medical director to sit down, and you may have to act as a mediator to come to some agreement. Because every time there's an irregularity, the irregularity is going to trigger a separate written report that has to be sent to the medical director, DON, and attending physician. And it has to have the resident's name, the relevant drug, and why the pharmacist thought there was an irregularity. And that irregularity then has to be documented in the medical record as to what action, which could be nothing, no action is an action, but the rationale for what the action of either taking one or not taking one needs to be documented in the record. So if the consultant pharmacists are using criteria that triggers a lot of irregularities and a lot of reports, you're going to have a lot of angry medical directors and physicians in your facility. And so you really need to have them sit down and come to agreement on what's going to go on, because you don't want the physicians, medical directors taking out their anger in documentation in the chart, because that just is not a good place to have disagreements come out. That's a gift to surveyors, it's a gift to trial lawyers, it's just bad practice that's going to end up harming the residents. And so I encourage you to make sure that they sit down and talk together on that process. CMS changed the definition of psychotropic medication. A psychotropic drug is any drug that affects the brain activities associated with mental processes and behavior. I, as a physician, and to the clinicians on the call, you're probably shaking your head. This applies to almost every medication. Frankly, acetaminophen or Tylenol meets this definition. We pointed this out to CMS. I'm hopeful that they will make changes in the future. But essentially what they really were is they're trying to focus on 4 classes of drugs: antipsychotics, antidepressants, anti-anxiolytics, and hypnotics. And that's really where they wanted to focus on. Certainly the Beers criteria, the BERS criteria medications that are out there often will affect mental processes. Anticholinergic drugs will affect them. But really CMS wants to focus on these 4 initially. And so any medication in these 4 classes now considers a psychotropic drug, which triggers a drug measuring review. It also triggers that you can't write a PRN order for a psychotropic drug unless you have a diagnosis and a condition and a rationale documented in the medical record. Which actually for some of these meds makes sense, because most antidepressants and antipsychotics take at least a week to 3 weeks before they're effective. So there really is not a role for PRN antipsychotics or antidepressants out there. If we are using on PRN, usually we're using for the side effect profile and the sedating profile. And so there may be better medications if you're looking to sedate someone acutely for a problem. PRN orders are limited to 14 days unless the physician documents a reason for going beyond that. Again, I think this is a little harsh, but you just need to increase the documentation. Certainly anti-anxiolytic meds may need to have longer than 14 days, because individuals have anxiety, panic attacks, and they respond well to anxiolytics, and they're not having them all the time that are out there. And so you may want to have that there, but you want to have that documented in that rationale so everyone understands that process that's going on. So I think that's another change that's out there. I want to quickly go through the facility assessment, and we get a lot of questions about this. On the facility assessment, again, the purpose here is that centers understand who they are, who the residents are, who their staff are, in order to determine the right resources, the right staffing, the right equipment, and able to deploy them effectively to provide care for the residents. And so the facility assessment needs to be done once a year, or if you have big changes, and it has 3 components to it. The first component is, what is the residents you care for? How many do you have? What type of diseases are they? What type of physical and cognitive disabilities do they have? What is the overall acuity? Because that will guide you, and many of us use that now, figuring out, how we staff by shift, the type of staff we might have. So for an example I gave you before, if you've taken care of a lot of people with respiratory illness or ventilators or trach care, you're going to want to make sure you have individuals trained in that area, access to respiratory therapists, access to oxygen, right competencies, right contracts out there for the right services to manage that are there. And that's, again, the purpose of this resident population, or the folks in the resident population. They also want to make sure that you do an assessment of your staff competencies relative to the residents that need care, the physical environment, the equipment, the services that you have, any ethnic, cultural, or religious factors that may come into play as well. So if you take care of a large population of individuals who celebrate a different religion or have different food preferences, how are you going to meet those? Make sure you have the right dietary setup, the right contracts with the services that are out there. This is not meant to be adjusted and changed for every single resident, but it's meant to sort of guide it. It also is meant to guide your decisions of who you might admit. So if you decide that you are not equipped to handle individuals with trach in your resident assessment, before you do, you either better meet them or you better not take them in, because if you take them in, you're going to be admitting someone that your facility assessment has said you're not equipped to take. And we see that that is a very common reason for substandard quality tags, large CMPs, and IJs across the country because of actual really bad adverse events occurring because someone took someone they weren't able to handle as they came into the building. The second component of the facility assessment is assessing your center. This requires all the buildings that are affiliated with your center, the equipment, both medical and non-medical. Do you have generators? Do you have boiler lifts? Do you have all the right things? The services that you provide, your rehab and pharmacy, particularly the contractual arrangements you have with them, all the personnel as well as volunteers that you have in the building, any contracts, MOUs, or other agreements you have with outside services or equipment to provide care in there, and your HIT resources. So we want you to sort of look at those and figure out what does that mean. Because part of this is also, the third component is to do a assessment of your center and community-based risk assessment using an all-hazards approach. And so it's really understanding how are you going to take care of individuals if you don't have electricity for a few days, and so your generator fails. If your staff can't get to the building because you've had a blizzard and they can't get there, how will you care for the residents? If there's a fire or an explosion or a toxic chemical leak, how do you evacuate the residents from your building that are there? And again, this facility assessment is meant to do that type of a process as well. As I said, it has to be updated annually, or if you're really going to change the population mix, not based on one or two residents, but if you're really going to fundamentally change who you care for. To end you on some changes in the physical environment, one, we now need to conduct regular inspections of bed frames, mattresses, and bed rails to make sure that there's no possible entrapment or risk of damage or injury, because we continue to see strangulations and other injuries around bed rails, mattresses, and bed frames. We're going to have to shift away from overhead call systems. So the call systems will need to be through a communication system which relays directly to the staff or to a centralized work area. A call light outside the room is no longer sufficient for that. This is a phase 3 requirement, so there's time to build this and install that, but that is a change for many of us. And needing to establish policies regarding smoking, smoking areas, and smoking safety that also takes into consideration non-smoking residents. If you have a policy that you are a non-smoking campus altogether, and you make that clear in the admission agreement before people come in, you do not have to make available a smoking area on your building. But if you do accommodate smokers, you're going to have to figure out how to accommodate them without also impacting the rest of the residents. Also, if your facility is newly certified for Medicare and Medicaid, has new construction, you're building a new building, or you're remodeling, and remodeling is defined as needing to get a building permit and or taking residents out of their rooms. So if you have to take the rooms out of the rooms and you need a building permit to do the work, any of that will trigger this. And what that means is that if the bedrooms, after you do the remodeling, cannot have more than 2 residents. So if you have 2 residents or 1 resident in a room right now, this doesn't apply to you. But if you have 3 or more residents in a room, and you're going to remodel the room for whatever purposes that you are, and you need a building permit for it, afterwards you can only have 2 residents in that room. It also triggers a private bath issue. So if you after doing newly certified and new building, we'll need to have a private bath for each room. This does not apply to remodeling. The private bath does not apply to remodeling. It only applies for newly certified or new buildings going forward that are out there. And this went into effect, this went into effect this last November. So I'm going to stop there. So we have, looks like 5 or 10 minutes for some questions that are out there. I know I went through a lot of things very quickly. Didn't cover other things that are important. I really would encourage you to get the last 30 pages of the Federal Register and read those 30 pages of the new requirements so you know what's out there, and keep them with you as you roll things out, as you go forward on it. And again, the mindset you bring to the table about person-centered care, what would I do if this was my family member, and how am I going to apply this to improve the outcomes of the residents I care for? And then you'll be able to handle this a lot better. If you apply this as, oh, the feds are making me do this, and I have to do this, the staff will resist it, the doctors will get angry with you, and people will not comply, and you will get deficiencies. So explaining it in the rationale to why it would help residents and approaching it that way is going to get much better compliance, and it will actually help the residents in the long run, and you won't be doing things that you feel are silly and redundant and not really helpful towards the overall care for the residents. So I'll end there and see if you have any questions.
Thank you, Dr. Gifford. We're going to open up the lines to address questions. To ask a question over the phone, you'll need to unmute your line by pressing #6. You can also submit a question using the chat panel that's to the right of your screen. Again, to unmute your line, you'll need to hit the mute button that's on your physical phone, but you'll also need to press #6. Do we have anyone on the line that has any questions?
There was one question in the chat function about notifying the ombudsman of discharges to the community. CMS recently just issued a new guidance from the S&C memo on this because there's been a lot of questions about this because the language and the requirements are written such that any discharge to the community, to the hospital, whether it's involuntary or not, needed to notify the ombudsman. Well, the ombudsman across the country said this doesn't make sense. They don't want all these notifications, didn't want the information. The problem is CMS wrote language and the requirements and finalized it are pretty strict. So the lawyers and everything else wouldn't allow them to do a lot of changes. CMS has come out with a recent proposed rule asking for input on how to change this requirement language that are out there. And they gave some guidance indicating that I think voluntary discharges back to the community did not need to be notified to the ombudsman. But different ombudsmen in different states have been taking slightly different approaches on this. I would encourage you to contact your state ombudsman and see what he or she would like to receive with them and what the state survey agency is planning to enforce with this. We have not heard anyone in any part of this country enforcing this aspect. If there's I certainly, with involuntary discharges or any discharges that are any contentious, I would just go ahead and send to the ombudsman until we get new guidance that is out there. I think there's this general agreement that I've heard from CMS ombudsman and state survey that this rule went way too far and that it needs to be backed off. How far it needs to be backed off, there's some disagreement, and we don't have the final language on that. So that's a pretty weak answer to the question on that. I would really turn out to your ombudsman and your state survey because they're the ones who are going to enforce this in the long run.
Do we have anyone that's joined the line with a question?
Yes, I have listened to this, but I wasn't able to log on to see the PowerPoint. Are you going to be able to send those out?
Yes, a link to the webpage for the event that includes a link to download the PowerPoint was sent out in an email reminding you of this webinar today. It went out this morning.
Yeah, I didn't get it this morning. That's why I wasn't able to see it. I had everything but the password, but
that's all right. You'll also get a thank you email following today's webinar, probably tomorrow, that will also include a link to the PowerPoint. And then anyone that is logged in on WebEx, we did provide links to access that in the chat room. You can also go to our website, healthcarefornewengland.org, go to the events section, and then find this webinar, and you'll be able to access the link as well. Okay, thank you.
There's a question about smoking. If a facility currently allows smoking, what are the guidelines already stopping smoking? I don't know. I don't think they specified that. Residents have the right to smoke. I would assume that as long as there's a resident in there who is smoking, the way I read this, and I'd have to go back, and this is where I encourage you to go back and read the actual language. You may want to check with your state survey agency. I think, or your ombudsman, I think you would not be able to prohibit them from smoking. But once they leave the building, and they're discharged home or they die, and they're not coming back and they're the last smoker, then I think you can make a policy and say we're smoke-free, and then you just need to notify all new admissions that they that you are a smoke-free campus and you don't honor smoking, and then you're good. But if they are a current smoker, my read on this is I don't think you can go smoke-free until they've been discharged from your facility. And discharging them because they're a smoker would be against their rights.
Dr. Gifford, we have another question in chat. Can you please clarify if a permit is needed if cosmetic updates to resident rooms is made?
It's up to your local building codes. I mean, I don't think painting a room triggers it, but certainly you just might want to check with your state survey agency on it, but I'd read the language. You may need to get your lawyers involved in it as well. If you don't want to do it and then discover after you did it that you cause problems. We've tried to point out to CMS that this is going to actually cause a damping effect on people's willingness to update and renovate because of the changes that are out there that they're requiring. But I do not believe general cosmetic things. Even painting a room where you may have to remove the resident from the room, if it doesn't require a building permit, I believe that that's okay. But again, you'd want to check with your, again, the state survey is going to be the one enforcing this.
Thank you, Dr. Gifford. Do we have anyone else on the line that has a question? We have another question in chat. Do you have any handy tools for us to review and assess our QAPI process?
Well, I'm assuming that's directed to the QAO QIN, or is that directed to maybe, we have them for AHA members, but I know there's not AHA members on the call, so I defer to the QAO QIN.
So, Lena, if you are a member of the HCA, you can access some great tools on the HCA website. We also have some QAPI tools on the New England QIN-QIO website at healthcarefornewengland.org. Click on the nursing home link and then nursing home quality, and you'll be able to find some great QAPI tools there as well. We have one last question.
And Leading Age has some tools on their national website too. I know that.
Absolutely. Yep. Yeah. We have one more question. I don't know if this was what you had already addressed or if this is additional. If the campus is a non-smoking policy for residents, can it still allow smoking for staff?
Ooh, that would be that's an interesting question. If I was an ombudsman or a state surveyor, what would I do? I don't see the language that specifically addresses it, but I think if you said, I allow my staff to smoke, but not the residents, and the resident wants to smoke, you get yourself in trouble. I'm just guessing. But you may want to clarify that with, and go back and look at some of the I'd have to go back and read the exact language, and look at the interpretive guidance. But certainly, even if you allow residents to smoke and your staff are smoking, you need to make sure that the residents, your staff are smoking in an area that does not impact residents who don't want to smoke. And then again, depending on your state laws on smoking, they may need to be a certain number of feet away from the building if they're going to smoke outside the building. And again, that would depend on your state laws.
Thank you, Dr. Gifford. Thank you all for the great questions. We're at the top of the hour. I just have a couple additional announcements. Can you pass the ball back over to me, Dr. Gifford? We just want to make sure you all keep a lookout for the invite to register for part 2 of this webinar series, which will take place on Thursday, June 27th at 11 a.m. Florence Johnson from the New England QIN-QIO in Connecticut will be facilitating this webinar and will answer any questions you have about the new requirements of participation and anything that Dr. Gifford covered today that you think of after today's webinar. We're specifically interested in learning what challenges and barriers you and your team are facing so that we can help provide the support you need to be compliant. In addition, you'll see on this slide that we have several educational events coming up this month. And for more information or to register for any of these events, please go to our website, healthcarefornewengland.org, and click on the events page. Following today's webinar, you will be directed to a survey to provide feedback on today's webinar. Your input helps us to improve these educational sessions and provide you with meaningful programs in the future. Also, within the next few business days, we'll be sending out an email to everyone that will contain a link to both today's presentation and a recording of the webinar. Don't forget to find us on social media to gain access to education and additional resources. You can find the New England QIN-QIO on Facebook, LinkedIn, and YouTube. And don't forget to follow us to get updates on future contests that we run. Last month, we did run a contest for 2 lucky winners who followed us on Facebook to receive 2 tickets to one of our upcoming pain management seminars with guest speaker Carol Curtis. The winners of this contest, I'm happy to announce, are Kathleen Kelly White and Kate Gamely Columbus. Congratulations to Kathleen and Kate. You each won 2 complimentary entries to the Assessing and Managing Pain in-person seminar, the date of your choice. If you, to claim your ticket, please email me at sderiuk@healthcentricadvisors.org. Thank you all for attending today's webinar, and special thanks to Dr. Gifford for all of the great information. Please have a great rest of your day.